Hey guys, it's Wade. Sorry it's so late. It's almost midnight here, but I wanted to go ahead and just throw this recording up for you guys. Um, Sorry if there's any background noise. I know that I got this PowerPoint up, but I wanted to go ahead and just make this recording for you guys. Um, Sorry, I'm running off of very little sleep, so if I'm not making sense, that's why. So, all right. So, the last lecture we spent talking about the rotator cuff, obviously arthritis and adhesive capsulitis. So obviously, guys, as we know, and as we've kind of said over and over again in class, the chief function of the rotator cuff is to compress the humeral head into the glenoid. So obviously, as the rotator cuff belly transitions towards the attachment, it turns into a tendon at the attachment site, right? And we also talked about how the rotator cuff muscle bellies themselves, either in regards to their health, can be either fully muscular or have some fatty infiltration, which then can affect the tissue extensibility of the cuff. Um, and then can also obviously affect the ability of a surgeon to repair the cuff if needed, right? So obviously, a healthy rotator cuff maintains proper dynamic stability of the cuff, right? Um, also, or of the shoulder, along with the scapular stabilizers, right? Because we have that 2-to-1 ratio, and that is a combination between of motion between the scapulothoracic articulation and the glenohumeral joint. So, if you guys remember, right, we went over the histologic layers of the rotator cuff, right? Going obviously um, from layer 1 to layer 5, right? And the thinnest layers of the thinnest histologic layers of the rotator cuff lie on layer 1, which is the bursal side of the tendon, and then obviously layer 5, which is the articular side of the tendon. We know that right over top of layer 1 lies the subacromial bursa, which provides lubrication to the tendon. And then obviously at layer 5, obviously, that is the true articular surface of the tendon. And most of our tears um, are actually articular sided, right? So layer 1, most superficial layer, 1 millimeter thick, generally composed of fibers that are contiguous with the coracohumeral ligament. Layer 2, obviously, composed of kind of densely packed fibers of the tendon um, that are about 3 to 5 millimeters thick. So that's our thickest layer, right? And then we have obviously layer 3, um, loose, basically organized loose collagen, 3 millimeters thick there, and then layer 4, right? Loose connective tissue and thick collagen, uh, and obviously merges with fibers to form the coracohumeral ligament. Then we have layer 5, right, which is 2 millimeters thick. That is the shoulder capsule itself. And as we said, the vast majority of our tears are articular sided. So, impingement, guys, okay, this is a really common problem. Impingement of the rotator cuff obviously is a chronic compression of the rotator cuff tendons, uh, usually supraspinatus, but can also happen with the bicep tendon, right? Under either the subacromial space or the coracoid. Generally speaking, this is going to present as a bursal-sided pathology, right? Generally due to overuse of repetitive microtrauma. Really common in people that do overhead movements, and/or people that spend a lot of time with their arms overhead. Right. So on our exam, Near-Hawkins impingement tests are going to be positive. And the cool thing about impingement in an athletic population is that we can generally treat this, right? We can generally treat it with rehabilitation, right? We can treat it. We can use exercise. We can use mobilization, right, to open up that subacromial space by depressing the scapula and retracting it towards the spine. So in doing so, we open up the subacromial space and cause essentially relief of the impingement on the tendon. Okay. Rotator cuff tears, guys. Remember, we've talked about post lesions. So we have partial thickness tears and full thickness tears. We know that post lesions are a type of partial thickness tear, right? So that a post lesion stands for a partial articular sided supraspinatus tendon avulsion. Okay, so this is obviously a lot more common in overhead athletes or throwers due to micro instability of the shoulder due to a slap tear, as we talked about, right? When we have a slap tear, the humeral head actually tends to kind of drift upwards a little bit and can actually start to grate on the undersurface of the tendon with normal shoulder motion. As that happens, back and forth, right, the tendon begins to delaminate and thin out and then lift away from the humeral head. And that is a pause lesion, right? So ultimately, this is going to be a finding on imaging, right? So this is not something that we're going to be able to diagnose generally right off the bat, but we do need to know that this may be an incidental finding on MRI, and this may be something that can be symptomatic in patients uh, that spend time in persistent overhead positions, particularly if we have someone that has a slap tear and they have persistent pain with overhead activities. A pause lesion may be to blame for those symptoms, particularly in combination with labral injury. Okay, so what about partial thickness rotator cuff tears? Okay, much like our pause lesions, right? These are going to these are also partial thickness tears, but they involve more of the tendon, right? So ultimately, what we need to do, right, is we generally break these partial thickness tears down by size. So small is 0 to 1 centimeter, right? And we typically characterize these tears as small, medium, large, or massive, right? Medium is a 1 to 3 centimeter tear, right? And then large, 3 to 5 centimeters, and then a massive tear being more than 5 centimeters. That typically involves 2 or more tendons. Now, one thing to notice though about the partial thickness tears is that partial thickness tears typically do not roll up and retract into the shoulder. I'm going to show you guys a picture here in a second of a full thickness tear, and the one thing that you will see with a partial thickness tear is that obviously the tendon has been disrupted and the muscle tissue actually retracts and actually pulls the tendon back away from the attachment. So obviously a key exam finding with partial thickness cuff tears is that patients are going to frequently present with pain above chest height and overhead, right? They're going to tell you, it doesn't necessarily hurt when I'm down here at kind of belly level, but anytime I try to reach above my head, it just absolutely kills me. And like we talked about in class, you may notice a bit of a kind of a difference in range of motion, and then a little bit of a shake, particularly with active forward elevation. Okay. Now, what about our full thickness tears? Okay, our full thickness tears. One thing I want you to notice is that these generally are massive tears, and they generally will roll up and retract away into the joint space. So we can actually see that you can see that this rotator cuff tendon has actually pulled away from its attachment site. So you can see this little divot in the bone, right, where the tendon came over and attached, but it is ruptured. And as a matter of fact, you can see how we have tendon looks okay. We got it, and then it just disappears right over the top of the humeral head. And ultimately, what we're going to see there, right, is that tendon is actually pulled off, and you can see how it's kind of rolled back and almost retracted to the level of the acromion here, right? So it's rolled back and retracted to the level of the acromion. Generally speaking, they'll go back in and attempt to fish these guys out and then tack them back down to the humeral head using suture anchors, right? So obviously, anytime we're taking a history, generally the older the patient, the higher the likelihood of them having a rotator cuff tear. Obviously, factors such as persistent smoking, obesity, and diabetes have been shown to actually increase the prevalence of rotator cuff disease and also tears. All right. Now, we talked about this in class, and I know we kind of moved through it a little quickly, but rotator cuff arthropathy, right? So those massive rotator cuff tears obviously lead to altered mechanics of the shoulder. And ultimately, what happens is with those massive tears, the rotator cuff loses its ability to create a force couple and to bring the humeral head into the glenoid. Okay. So here's what happens, right? As the rotator cuff itself tears and retracts, the humeral head actually begins to migrate superiorly. Okay. And you can see, um, and we'll talk about this more in a second, but here's Shenton's line, a nice, beautiful, continuous arch, right, from the medial humeral shaft all the way through the scapula down to the rib cage. And what you can see is here we have a nice continuous line, right? However, in the presence of a massive tear, Shenton's line has been disrupted, and you can actually see the superior migration of the humeral head, right? Now, the problem though becomes that because we lose the force couple at the rotator cuff, the deltoid actually takes over here as the prime mover of the shoulder, right? And ultimately, what happens is the deltoid continues to kind of dominate as the primary mover. It continues to pull the humeral head superiorly, and then we start utilizing the acromion as basically a hinge or a lever, right? And so what happens is the acromion will eventually start to basically be broken down, and that's called osteolysis, and or it will essentially start to curve, okay? And that's called acetabularization of the acromion. So what can happen with rotator cuff arthropathy, and you can actually even tell here as well, that you can look at this nice healthy joint space between the humeral head and the glenoid here, uh, with a normal intact cuff, and you can see obviously here that where we've lost glenohumeral joint space, and we're starting to see some arthritic changes at the glenohumeral joint. Okay, so lastly, guys, adhesive capsulitis. So adhesive capsulitis, abbreviated or also known as ADCAP by a lot of people, is a condition obviously that essentially presents as progressive loss of range of motion of the shoulder, right? So progressive tightness and stiffness and pain without a known mechanism. So this can be due to it can be traumatic sometimes, but it's most often atraumatic, right? And generally patients are going to present with progressive loss of range of motion and stiffness, right? So often quick movements of the shoulder with ad cap are extremely painful. One thing that you can often do, although be very careful with this with your patients, if you suspect a patient has adhesive capsulitis, you can actually just take the arm passively and just quickly externally rotate it. And if they have ad cap, they'll jump off the table and they might even slap you. Because it'll be very painful. So quick movements of the shoulder are often very, very painful, right? One thing that you'll often find, particularly if this presents in younger people, is that generally speaking, they either have a history of smoking, they either have a history of tobacco use, and or they have a history of diabetes, and this is known to be a big contributor. To adhesive capsulitis. And one thing that you'll notice about adhesive capsulitis is that adhesive capsulitis is actually broken down in two stages, right? So it's essentially a freezing stage, freezing with pain, uh, freezing with stiffness, right? And then a thawing phase where motion actually gradually returns over time. So ultimately, at first, the shoulder will be very painful. Uh, and then they'll lose some motion, but then in the frozen stiff phase, they'll start to really tighten down, and they'll have decreased range of motion where they can no longer perform activities of daily living, like reaching above chest height, putting things away that are above chest level or above their head, right? And then over a period of about 5 months to about almost 2 years, the shoulder will actually calm down and will thaw, and then we'll actually get motion back. All right. So, guys, that is it. Thank you so much. Um, and sorry for the delay in getting this up. Time has been kind of bananas, but that's everything. Okay. I hope you guys are doing fine. All right. Bye.